Hi, welcome to Fertility Talks. I'm Mary Wong, and I'm the founder of Alive Holistic Health Clinic, author of Pathways to Pregnancy, and your acupuncturist and fertility coach. Today, I'm super excited to be here because we have Dr. Hannam in the house, and I'm going to introduce him in a second, but the reason why we're here is to really provide you accurate information based on the most up-to-date research as well as professional insights into this. So we're going to talk about PCOS, natural medicine, and your REI experience at the fertility clinic simultaneously, okay? So let's get on with it, and before we get into the meat of all this, I'm going to introduce to you, actually you're going to introduce yourself.
I'll introduce myself. Thank you, Mary. Well, hello, I'm Tom Hannam. I'm here in my capacity as owner of Hannam Fertility. We're a downtown Toronto clinic. We have a partnership with CCRM Labs. They're out of Denver, Colorado. So what we provide is diagnostic services, lots of different services, ultimately culminating in IVF. So I think I'm here today really to speak to the diagnosis of polycystic ovary, PCOS, what we see, the patient experience, and ways that we can help people try to integrate with more natural approaches. Some people will need IVF, but not everybody, and just helping people sort of negotiate those decisions.
Well, and so I love it because I didn't actually ask for this. I said, hey, what should we talk about? And it was Dr. Hannam's insight that said, we should talk about the integration of both. Because here's the thing, there's a myth. Sometimes people think, if I pursue IVF, then that's all I'm going to do. Right? Or if I'm going to try natural medicine, that's it. I'm not going to go do Western intervention.
Yeah, but they're different. Like, they're complementary. Like, they make sense together. And I wouldn't choose to do one. If someone's in our practice, if someone's doing IVF, I'm extremely supportive. I'm encouraging. I hope they're also looking to natural approaches at the same time, because natural approaches are about maximizing overall health, maybe very specifically maximizing egg quality.
Yes, so did you guys hear that? Maximizing egg quality and simultaneously reducing the stress that goes with the burden of facing fertility challenges.
Yeah, there's a huge burden associated with it, but we're getting ahead of ourselves.
Yes.
Before we go to IVF, let's try to just sort of pull back from the edge there and just talk about what most patients might experience.
Okay, so in fact, because we're actually talking about polycystic ovarian syndrome,
yes,
or PCO, let's define that for
sure. So PCO is short for polycystic ovary, and you would think, because many people do, that means the ovary is full of cysts in a scary way. Maybe there would be symptoms, just physical symptoms from having ovarian cysts. Ovarian cysts can be a significant concern for women, but that's not what PCO is. It is the name, I agree, but it's not a great name because these are tiny cysts. These are little, they're 2 millimeters. So it's actually not a problem. There's no particular symptom or health consequence from having lots of these little 2 millimeter cysts on the ovaries. Each one of those little 2 millimeter cysts is meant to have an egg inside of it. So someone who has PCO simply has a lot of eggs. In fact, all by itself, PCO is a good thing. Like, there's nothing wrong with having lots of eggs. It's a good thing. If you were going to have a choice, you'd be like, as a fertility person, you'd be like, well, I would rather everybody has lots of eggs. I would love it if all patients had PCO.
Yeah, and people get scared by it. So I love it that you address this, because they come in scared, like, oh my gosh, that means my eggs are like crap, right? But
no, that's not right. Exactly.
Yeah, exactly.
Now, it is more complicated for women who have PCO, which just means lots of eggs, but plus one more thing. So PCOS is plus one more thing. So lots of eggs plus either too high androgen levels or, more commonly, irregular or absent cycles. And that's the essential challenge. So naturally the way it works, oh, look at that. Someone's, I think someone just wrote in.
Possibly. We're going to ignore it for now.
Polycystic ovary syndrome is too many eggs plus ovulating irregularly or maybe not at all. And that's because eggs hold each other back from growing, which is a good thing. So women each month will have like a group of eggs, like maybe 20 eggs, and one will grow and the other 19 will disappear, and the next month is another set of eggs. It's a good system because you wouldn't want to be ovulating 20 eggs at once. However, if it's more than 20 eggs there, if it's 25 or 30 or 40 or 50, if it's a really high number, then that holding eggs back from growing is what dominates. So instead of an egg escaping and the woman ovulates around day 13 of the cycle, maybe she'll ovulate on day 17 or day 21 or day who knows when. And so that means the woman's experience is ovulating who knows when, maybe not at all, which makes it, well,
very challenging when you're trying to conceive.
Or impossible.
Yes.
You know, like how are you meant to time intercourse to that? And so women get these funny signals of, on the one hand, it's so great, you've got so many eggs, your prognosis is awesome. On the other hand, their lived experience can be months or even years of not getting pregnant because they're not ovulating naturally. Mm-hmm. And nobody can get pregnant if they're not ovulating, and very few people can get pregnant if they have absolutely no idea when they're ovulating.
But we do see it. I mean, there are women, they have PCO and they actually don't have issues conceiving even when their period cycles are like 3 months. Like we see
absolutely.
It, right?
It's just for them. It's just a timing issue.
Totally.
Yeah.
Yeah. So it's not all bad, and in fact, it's not bad. It's just how do we manage it? Really, is what it is.
Yeah, and so but it's in that space that it's so tricky for patients because they're told all the time, "Oh, this is good. The only issue is polycystic ovary syndrome. Everything's going to be okay." And big picture, that's a reasonable story for most people. But months go by with no pregnancy, and so that the lived experience can feel very different from what it is that we clinicians are telling people.
So, okay, let's bring it back to this then. You have a person who's not ovulating, they're not experiencing menstrual cycles, or if they do, it's 60 days, 35 days, just all over the place. Mm-hmm. So now what? What are we going to do? We've been trying for 2 years.
The first thing you want to do is actually get the diagnosis. So there's PCO is not the only reason that someone might have irregular cycles. Now, the good news is it's a pretty quick diagnosis to be able to make. A single ultrasound, probably an internal ultrasound, transvaginal ultrasound, will count how many follicles there are. So right from that, like the first time you get an ultrasound, you should be able to know. Other ways of counting ovarian reserve include AMH. It's probably the most accurate way to tell someone how many eggs that they have. So between the ultrasound and the AMH test, you can offer the diagnosis.
Yes, and I'm going to just add to that because when it comes to AMH, you're going to say the most accurate, yes, to date, yes, but I've witnessed women then freak out when their AMH is low, right? And I just want to go back to and address that it doesn't necessarily mean you can't get pregnant. And in fact, I have 2 women right now, they have like negligible AMH, like we're talking 0.0, and they're both currently pregnant.
Right, because AMH is not a test of egg quality, but it is a test of egg quantity.
Yes, absolutely.
So if their AMH is 0.0, that means it's beyond the ability of the test to tell that there's eggs. They must have eggs because they're getting pregnant.
Yes.
And they're obviously good eggs because, again, it doesn't tell you how good the eggs are. But those women don't have polycystic ovary.
No, they're the complete opposite. They're being told, oh my gosh, you're going to go into menopause any second now. Opposite.
Yes, and it will be sooner than they might have thought. That's true because their ovarian reserve is so low. But again, nothing to do with inequality, nothing to do with their ability to get pregnant naturally.
Yes, and I love it that we need to add that in because people hear one thing and then all of a sudden they tell themselves such negative stories.
Right. And it's the same with a person with polycystic ovary. That doesn't mean that they have good eggs. It just means they have a lot of eggs. It doesn't mean that they're bad. But most of the time they're good eggs because most people have good eggs. Most people do.
And thank you for saying that. Again, because people will walk in our door and say, oh, I have crappy eggs.
Well, their lived experience is not getting pregnant for such a long period of time. And so if it takes 1.5 years to get pregnant and then you lose that pregnancy, it would absolutely feel like they're terrible eggs. And whereas it may well just be that they got pregnant the first time they could and it happened to be a loss, which is unfortunate. That happens.
But it's very frequent.
But it's frequent, right? So it doesn't necessarily mean bad eggs.
Thank you. So everybody should be watching this for sure to hear this. No, because again, the lived experience is I get my, I have my past. I had a failed IVF or failed or miscarriage, multiple losses, or just not getting pregnant at all. Yeah. And the automatic conversation as a woman is, I'm a failure,
I know.
And I have crappy eggs, and this is never going to happen.
Yeah, which is not fair.
No.
And I think that's why as clinicians we're often like, no, please don't do that to yourself. You should have every hope and confidence in the quality of your eggs. but then their lived experience still is that it just takes too long. So I feel like our goal with this talk today really is just to help people speed the process up. Because one way a person can get pregnant with polycystic ovary syndrome is just to wait a long time. This is not a solution, by the way.
Yeah.
But it's not. But over time, all women will start to run out of eggs. So women with polycystic ovary, over time, will go from her super high number of eggs to a more normal number of eggs, at which time she can expect to have regular cycles and be able to time intercourse accordingly, but she might be waiting a long time for that to happen. She might be 38 or 39 or 41 or 42 before she's able to enjoy just a predictable cycle like everybody else.
And no one on this planet, when they want a baby, is going to wait.
They shouldn't.
No. So then let's go to the next conversation. What are you doing with them?
So what we would want to do after confirming that there's a lot of eggs is we try to find some other medical reasons that might be the case. Things that are reversible. So, for example, there is an association with being hypothyroid. Again, simple blood test. When you're checking the AMH, you can do a TSH, check the person's thyroid, because that's a very welcome solution. If the person's hypothyroid, you might be able to treat that. That might be the issue. For other people, it might be that they are diabetic, or there might be lifestyle issues. They might be underweight or overweight. Anything that affects the hormonal system can ultimately affect the ovulatory system and present as PCOS.
So again, and this is where we want to bridge the gap, right? Because you just said it. So there's certain lifestyle things that one may be able to be responsible for on their own that you may not have a clue. It's like you're just living your lives, right? So learning about it, then you can change your lifestyle. That may be more conducive for
if you have to. And so that's the part where I would want people to actually come and see you, because it's not that everybody has to change their lifestyle. So when you do reading about PCOS online, you'll see all kinds of stuff about weight, and what a hot button topic that is for all of us, for everybody.
Yes.
There are some people who, if they lose weight, they're more likely to start to ovulate regularly. But there's many others who would lose that same weight and that wasn't actually the issue.
Yes.
Right?
True.
Or their weight's absolutely fine. They may or may not be satisfied with it, but it's not of medical concern. Everyone's quite different.
Right. And there are those that have a high BMI and they still ovulate very regularly as well. And still have PCOS.
Mm-hmm. Mary, when you see people, let's presume that they were worked up appropriately by their family doctor or a gynecologist or a fertility doctor. And so it seems that they have polycystic ovary, so they have a high number of eggs, they're not ovulating regularly, thyroid's fine, they're not diabetic. What do you do in those moments? What do you do to help people optimize lifestyle?
So yes, we do definitely actually look at the dietary piece and movement piece for sure, but as you say, it's not the end-all be-all. And in terms of technical intervention, we do definitely utilize acupuncture and there's some good research now on polycystic ovaries and acupuncture and helping to actually normalize the menstrual cycle.
How does it work?
So,
no, I don't know.
You're interviewing me now.
I know.
What's going on here? Hey. So, when you do the acupuncture, there are specific sites, and depending on each individual, we'll do it differently. So it's not like we don't base it on a very specific protocol, because guess what? We're all different.
Okay.
Now, if they're actually using something intervention with IVF, we'll be really strategic. And you might have noticed we always ask for, can you bring us your stimulation sheet? We want to know which side of your ovaries are doing more. Sometimes there's different cohorts of eggs that are growing at different times, and of course I think you all know that when you're doing IVF, you're wanting all the follicles to grow at the same rate, so that when at the time of retrieval, you want to maximize the number of eggs retrieved.
So Mary, do you see the acupuncture is trying to maximize blood flow? Is that the essential mechanism?
So one of the theories is yes, and we know, and actually at CCRM, the Colorado Center for Reproductive Medicine, they've been doing it for years, where they've noticed that when we do acupuncture, there's an increase of blood flow, and they test it through the Doppler ultrasounds. In Canada, they don't really do it so much. Mm-hmm. And so, in fact, in CCRM of the South, because you guys are the North, it's part of it's like their curriculum, so to speak. It's part of their protocol. They've got it written down. They say, okay, start acupuncture for 3 months before, because we want to increase the blood volume. And when we increase the blood volume, we're increasing oxygenation, we're increasing nutrients to your ovaries and your eggs, ultimately, maybe enhancing the energy, the mitochondria in your cells to help with cellular division down the road.
Have you seen acupuncture work to help an anovulatory woman start to ovulate regularly, or regularly enough that she can get pregnant naturally? Okay.
Yes.
So when it doesn't, because it depends on a woman's ovarian reserve. But there are some people where it just won't be enough. Like the acupuncture and or lifestyle change won't be sufficient.
That's
she
right.
still won't be ovulating regularly.
Absolutely.
So that's where we start to use the medications. Our first line medications are usually letrozole or clomiphene. Sorry about this, my hand's huge on the screen. Those are the most common 2 medications and depending on who a patient sees, they'll get one or the other. In Canada, we are generally preferring to use letrozole. In the US, it's generally clomiphene as a first line.
Yeah, and they're both oral, so it's much less invasive than the injectable.
Yeah, it's they're easy to take because it's oral.
Yeah.
It's just a tablet or sometimes 2 tablets for 5 days in a row. That part's easy. Oh, and they're both they're inexpensive medications whether or not you have coverage.
Right.
So you can anybody listening to this what do we call this? Facebook.
Well, it's Facebook Live, but it's going to be uploaded to YouTube, so you can watch it through YouTube.
There we go. Thanks, Mary. Is going to be able to access this. There won't be a financial barrier to using it. There are barriers, though, to both medications, to both the letrozole and the clomiphene, and it comes down to both of them have side effect profiles. So of the 2 of them, I think the clomiphene has the more profound side effects. I don't like clomiphene. I don't like its long-term problems. Short-term, the main side effect is that when it does get eggs to grow, it's not always just 1 or 2 eggs. It can be 3 or 4 or 5, which is infrequent but does happen. And if it's going to happen, it's more likely to happen to someone with PCOS. Someone who has a lot of eggs, they're more likely to get a bigger set coming through. That's actually significantly less of a concern with letrozole.
Right, yes.
Yeah. So that's one problem I have with clomiphene. But the other much bigger...
But wait, tell them why. Why is that a problem? It's like, why is it bad to actually have so many eggs at one time?
Well,
not everybody knows. You have to actually tell them, right?
So that's fair. I just want, for people who want to build a family, I just want them to be able to do so in an efficient way. And I have to say, for most people, most of the time, if they're so lucky as to have twins, that would be an acceptable outcome. However, twin pregnancies are not as safe a pregnancy. Also, it's not always going to be twins. It could be a triplet pregnancy or higher. Just extremely serious outcomes. Basically, anything that you would worry about for your pregnancy is greatly amplified as soon as you get into multiples, especially high-order multiples. And it's just not a concern with letrozole. It's possible, but functionally for you and your single cycle going through this, you can really feel significantly safer with letrozole than you can with clomiphene. I don't mean to be saying clomiphene is a really high risk medication, but multiples is a material concern.
You don't
and
have
it
to
happens with some real frequency.
You don't have to convince me because I like letrozole better than clomiphene does.
Right. So the risk of multiples and high order multiples depends on what you read with clomiphene. Might be as low as 12%, might be as high as 24%. You'd have to talk to your clinician about what they think your personal risks would be. The problem I have with clomiphene as well, though, is the side effect profile of the medication. The way clomiphene works is it blocks estrogen. So it fools your body into thinking your ovaries aren't working, and so it stimulates your ovaries a little bit more. That's how you end up with more than an egg sometimes. Yeah. But the lived experience is blocked estrogen, which might be fine for one cycle. But if you don't get pregnant the first cycle, you're often encouraged to do it again, and then again, and then again. And it actually, there's a long half-life for clomiphene, so it's building up in the system. So those anti-estrogenic side effects build up. And being anti-estrogenic is a highly problematic way to live. So it's hot flashes and vaginal dryness and depression. I think that's it's a lot of mood stuff associated with clomiphene, which I just find so sad. Because we get into, once you get into a pattern, it's hard to break that pattern, and to add that on top of all the challenges of fertility in the first place, and as you opened with all the tendency towards, self-harming, self-loathing things, I have a real issue with clomiphene. Maybe not for one cycle or two cycles,
yes,
right?
yes.
Because the side effects for most people haven't built up too much in that time, so 1 or 2 cycles, yes, absolutely. Again, inexpensive medication for someone who doesn't mind the risk of twins. I feel like letrozole is a more sustainable medication for someone who wants to try this for 2 or 4, even 6 cycles in a row.
Letrozole, not clomiphene.
I think. Yeah. What's your experience?
I totally agree with that, and I just want to add to this. So there are some family physicians that may say, you know what, just try Clomid. And then they're not monitored at a fertility clinic, and they're not doing ultrasounds.
Right.
So you have no idea how much you're producing.
No.
And so that's a huge risk. And I've had it maybe less often recently, but I tell you, I've had patients that come in and say, oh yeah, my doctor put me on, I went on it like 5 times, and I'm thinking, whoa.
It is less now, isn't it?
Yeah, it is less.
I think the word's out there now, but there's just no rule for it. But yeah.
Anyway, but the other piece that I wanted to add in terms of the side effects of Clomid over time is thinning of the uterine lining.
Yeah.
And when you're trying to conceive, also it may also decrease the cervical mucus, which is what you want. Like it helps the sperm swim up there. Right?
Yeah. These are also the anti-estrogenic side effects.
Exactly.
Yes.
So we're adjusting all that. Anyway, let's not belabor that. Let's be more positive.
Well, hopefully it works, right? Because when that works, it's great, because then you just get to get pregnant naturally, right? You can have intercourse at home, or if you're using donor sperm, an insemination can be done, or if intercourse is difficult for you, then do inseminations. I don't think that inseminations are uniquely a part of someone a patient experience who has PCO, unless they want to medicalize the process of the sperm getting into the person when they're ovulating, but otherwise, I don't get it.
Yeah, well, I mean, the time I see it would be when there's actual issues, either male factor, not true male factor, meaning the difficulty of erectile dysfunction.
Absolutely, or just situations like that. Like a couple might have a great sex life, but would prefer that, this sort of heightened event, like I'm ovulating right now, like maybe they would rather, but that's a personal choice. It's not it's not medically necessary. It's because it's helping them reduce their stress.
Yes.
I'm a big fan of IUI if it's reducing stress, but not if it's adding to it.
Absolutely, because you have to go to the fertility clinic and get monitoring. So you're going multiple times through your menstrual cycle, right?
So that's the issue, right? Because it's if you look at the stats of getting pregnant, again, it's hard to personalize these things, but let's just say it's a 20% chance per month. It's not a bad placeholder. By implication, then, it's reasonable to be trying for 1 or 2 or 3 or 4 or 5 or 6 months, and most people can't do every month in a row for a variety of life reasons. So this story can really go on. It can be 8 months of a life, or 9 months, or longer, and different anniversaries along the way. So at some point, it may not be the appropriate treatment. Mm-hmm. And that's why people would pivot to doing IVF. With someone with polycystic ovary, it's rare that we would say that the passage of time is going to take the couple away from being able to build their family. It's just the passage of time sucks. That's it.
Period.
Yeah, but that's a huge, all by itself. That's a big deal.
Of course. Yeah, thank you for addressing that, because it is like that. Every passing month, as a failure, you feel more emotionally beat up. Yeah,
right. To be amplified by all the, as you say, all the poking and the prodding and all that kind of stuff.
Mm-hmm. Yeah.
I think that it's really the 2 week of the whole thing. It's really the 2 week wait that is the hardest part. So the 2 week wait is our shorthand for after ovulation. Why do I keep putting my hands up? They're so big.
You guys, this is live. This is live. So this is what you're going to get.
All right.
Big hands.
Exactly. So the 2 week wait after ovulation, but before you find out if you're pregnant, that's where you're just hopeful, and there's nothing more to be done in that moment. And the problem is that pretty anxious around the outcome, and when we're anxious, we have self-soothing techniques pretty much all of which have been taken away during the 2 week.
Yeah.
So if your self-soothing is to exercise every day, that's great, but there's a lot of things about maybe you shouldn't exercise too intensely every day. So then people will be like, I know what I'm going to do. I'm going to drink, which, you can't drink when you're waiting to find out if you're
That's
pregnant.
right.
Can't smoke. Can't eat tubs of ice cream. Like, a lot of our self-soothing things are not necessarily healthy, but maybe they are. Maybe they're reaching out to friends, but a lot of people don't want to reach out to friends around this. So then they're isolated. So, as I said, pretty much anything that you can name that you would normally do to be taking care of yourself has been taken away. So people's anxieties are starting to peak, and at the end of which, there's an 80% chance they'll have a period and have to consider doing it all over again.
Yeah.
And so that pressure builds up over time.
Absolutely. And from one cycle to the next, and then you're looking back at your past history, you're not getting pregnant, so that anxiety builds up more and more for those 2 week waits, right? So I address this in my book, Pathways to Pregnancy. I have a little section on the 2 week wait, and what's so funny was the actual manuscript was 140,000 words, and they had to bring it down to 72,000, right?
Really?
So, and the editor... Yeah, right. So the editor said, okay, we're going to take away this. And it was a 2 week wait. I'm like, hello? If anything, this is the one thing that
that's
stays.
The key part, yeah.
Totally, right? So anyway, for those of you who haven't read it, I'm making the audio version of my book as we speak.
Oh, good.
So I know a lot of people... I'm narrating it because people will identify with my voice, so I'm doing it, okay? Because it's my book. So, I'm trying to do my best, but there may be little errors here and there, but that's okay.
Mary, I feel like in your space, you are able to have conversations with people that they might be less comfortable having with me or in a fertility setting. This is a loaded question, but how long do you think people with PCOS can go through the medicalized experience, taking these medications like clomiphene and letrozole? How many months can someone do this for before they have to seriously start to consider IVF?
That's a really great question, and really, honestly, guys, I know people love a fast answer, like, everyone should just follow a certain protocol, but really, I think it depends on each individual's resilience, right?
She didn't answer.
I did answer. It's individualized.
All right, I agree.
So, I asked them, I said, listen, how long are you, I'm in the position to say, you know what, you can probably do this on your own.
Yeah.
You have no idea how long. So are you able to keep going the same way you're going, or is it too much? And when is enough? And you get to say. And we'll support you in your journey. And because, listen, I think they can do it on their own. I think they can do it through IUI. I think they can do timed intercourse with drug. I think they can do,
until it's not the right thing anymore.
Exactly,
yeah.
Right?
I know there isn't an answer to it, is there?
No, there's no hard, fast answer.
So in our medical space, guidelines have suggested 3 to 6 cycles. That's been pretty common. But those are based on statistics. So it's not taking, in my opinion, the lived experience into account at all. And as we said, 3 to 6 cycles might take 4 to 12 months to complete. And that may or may not be the right thing for an individual.
And I'll say for most, just being at the clinic, most people will say, no, I can't do it. Like, they'll say at max 6 months, and then let's go to IVF. That's typically what happens.
Okay, so I'd like to talk about the advantages of IVF, but the 2 big disadvantages as well, which is hyperstimulation and cost.
Absolutely.
I think those are the 2 big ones.
Yes.
So the great advantage with IVF is you can take the injectable medications. So the injectable medications, this amazing, this great advantage. Is that what you laugh?
No, I'm laughing because, okay, guys, he's drawing.
Oh, I'm drawing little squares.
He's drawing squares as we're speaking.
Yeah, I know. Excuse me while I do some squares. Do some square work here.
That's his self-soothing technique. So maybe when you're in the IVF process in the 2 week wait, you can just draw squares.
That's fair.
Okay.
I'll put my pen down. You can take, if you're choosing to do IVF, you can now take the gonadotropins. These are the injectable medications. So what's so good about them is they're a synthetic version of your natural hormones. So by themselves, there are literally no side effects. So if you took the right dose to only get 1 egg to grow, it would just feel like a natural cycle. Now, You can do that with IVF. The problem is the IVF success rate with only one egg is about 7%. So it's low enough that most people would choose to take higher doses. If you want to maximize success rates, the goal is to get between 15 and 25 eggs. It's a lot of eggs at once. To do that, you take these hormones for about 9 days in a row. So the IVF experience is actually only 9 days from usually the beginning of a cycle, but a woman with polycystic ovary, you can actually start often at any time.
Yes.
And they take the medications for 9 days, at the end of which there are 15 to 25 eggs growing, which means 15 to 25 follicles, cysts, not like little polycystic ovary cysts, 2 millimeters, but like big ones, 17 to 22 millimeters in size, so 2 centimeters each, times 15 to 20, it's a physical experience for women.
Absolutely, and that's with women with PCO, not for
right.
the regular
So women
population.
with a lower ovarian reserve might have a fairly benign experience going through PCOS, but through IVF. But women with PCOS are more likely to have a lot of eggs growing, and actually, as a fertility doctor, it can be really difficult to get the dosing right. These women tend to have good eggs.
Yes.
And they tend to be very responsive to the medications. So it is not impossible to get 30 or 40 or 50 eggs growing, no matter how well you try to do the dosing.
The good news is that typically women with PCO, they get to go on lower dosing of drugs, right?
Yep.
So.
The medication cost can be half of what it is for other women, and it's good. I mean, it's a good thing to be able to get so many eggs as that. It's what you want if you're going to do IVF, because when there's let's say easy math, there's 20 eggs. It takes about 4 eggs to make a blastocyst. A blastocyst is a healthy looking embryo. So from 20 eggs, you might expect to get 5 blastocysts. An average patient, about 70% of those will be genetically balanced, 70% of those will implant. So from the 5 blastocysts, you might anticipate having 2 babies, maybe even 3. So for a woman with PCOS, she might only have her have to go through IVF once. And you can do those embryo transfers 1 embryo at a time. So, if you want to take on the risk for multiple pregnancy and put into, well, it's a conversation between you and your doctor, but there's no implicit risk to doing this once you've got the eggs. So the issue with IVF are the physical experience of having just that bloating feeling of lots of eggs, and the cost, I would say. That's the issues with IVF. Yeah,
and bloating is relative, right? So they're experiencing really severe stuff, like symptoms.
Yeah.
And one of the questions is, can I still exercise? I'm like, you know what? When you have this many, you're not going to want it.
Yeah.
And the other thing you don't want is the risk of ovarian torsion. It's like they're top heavy. You're growing massive ovaries all of a sudden.
Yeah.
It's not normal.
Yeah.
So you're not going to want to do it anyway.
Mm-hmm.
Right?
You're not using up your eggs when you do this. All you're doing is taking that month's eggs. Remember how it works naturally? One egg grows and the others all disappear. Well, now you're just getting them all to grow. So
in that one cycle.
Yeah, in that one cycle.
Yeah.
So you're not rushing yourself to menopause or anything like that. It's really safe. It's really effective. It's physically consequential.
Yes.
And boy, it sure shortens the timelines to pregnancy, though.
So then I want you to address, you just said it, you said it's really safe. So what does that mean? Because people, when they look at drugs, they think, oh my gosh, maybe it's going to cause cancer.
Right. So was always a theoretical risk, but we've been doing IVF for so long now, and there's some great big population databases, like in Israel, where you can have IVF up to having 2 babies. It's covered by the government, so lots of people do a lot of IVF. And anyways, as I said, great databases demonstrating that there do not seem to be increased risk of ovarian cancer, for example, above that you would otherwise have expected from the fertility population. So the risks appear to be acute to the cycle. Like, what are the consequences of having a swollen ovary in that moment? Well, as you said, ovarian torsion, super rare, but can happen.
Yes, of course.
Super common is those big ovaries just blocking everything up, so crazy gas pain.
Yes, gas pain, constipation.
Right.
Just
there's just not enough room in there for those swollen ovaries. And you'd think after doing the retrieval, when they take the eggs out, that everything will go back to normal, but it doesn't. The eggs come out, but the ovaries stay swollen for usually about 7 days or so afterwards.
So then let's cover this, just because we're on this topic. So because you're all swollen up, you're not going to want to do IVF fresh transfer because, the thinking is, fresh is better, fresh is better. But if you're like so swollen up and like filled with
hormones are all over the place.
Yeah.
Right. The trick is you take the eggs and the sperm and you bring them together and you create the embryos and then you freeze the embryos. You can put them back in, but you're taking on. Well, the hormones are all over the place at that point. It is incumbent though that you work with a really good lab. I mean, it's one of the reasons you're here, Mary. You trust us and our solution here. It is tricky for Canadians. There's no standard way of reporting success rates. There is no way, unfortunately, as a Canadian to know exactly where the best lab is. That's not the topic of the moment, but it is something that...
I'm going to do that on another talk.
Okay, but the trick, it is reasonable to look for second opinions on your way to finding the right IVF place for you, because ideally, as a patient with PCOS, if you end up having to do IVF, it would probably only ever be once. If you go to a great clinic where you get a good ovarian response, it should be safe, and you should have a lot of embryos and be able to build your family from that.
So, if you have a lot of embryos, are you recommending PGTA?
Not so much. So
okay,
PGTA is PGTA is genetic profiling of embryos. It does add to the cost, but let's take that aside. Many women with polycystic ovary syndrome, they're also young. They're under 35. It's two sides of the same coin, lots of eggs and ages on their side. And for women under 35, PGTA often does not increase pregnancy rates.
Did you guys hear that? Not increasing pregnancy rates. Then why are you doing it?
So it's worth it for someone who has a different story on top of those underlying worries with PCO. So there will be some specific situations. Someone with recurrent pregnancy loss. Yes, she's under 35, but she's experienced enough losses to have a factual basis for worrying about egg quality. Some people might be, for other reasons, might be needing to work with a surrogate, and so they really need to increase the success rates on a per transfer basis. It's not clear that it will happen with the PGTA, but it might. So there are occasions where it's appropriate, but as a general principle, I think that IVF for women with PCO should be very simple. It's about minimizing the interventions rather than layering things in.
Very good. And then in terms of the half-life of the injectable drugs, how long does that last?
So the injectable medications don't last very long in a person's system. That's why they have to take them every day. Now, the consequences of the medications can. So they're taking the medications and it's swelling up the ovary, and the ovary is going to feel swollen up for 5 to 10 days. The hormones being made by that ovary are going to be super elevated for 5 to 10 days. But the actual injectable medication is long out of the person's system.
Okay, cool. So again, no long-term side effects. And
no, short-term.
Yes. And then in terms of, there are some women that are PCO and they'll want to do banking. There's a whole popularity now of banking.
Do or don't want to.
That do want to do that.
Yeah.
So, in that case, are we doing IVF back to back, or what are you suggesting?
So, women under a ton of pressure. Look at me, I'm drawing circles now. Put my pen down. Women are under a ton of pressure to be completing their family in this really narrow band. So we know that a woman has a lifetime of the same fraction of earnings if she has a first baby before the age of 30. Then again, notionally, biologically, everyone's meant to have completed their family before their age 35. So somehow everyone's meant to have all their babies between the ages of 30 and 34. It's an impossible set of pressures, but that's the pressures that women today are facing.
And it's unreasonable because we have a whole different social way of being, and who's getting married? I mean, everyone's working and trying to make a living. They don't even have a boyfriend, never mind trying to have a baby.
Right. So some people will be lucky. They'll be like, they wanted to have 2 or 3 kids and somehow it happens at age 30, 32, and 34.
Yeah.
Great for them. but not, it just won't be everyone's story. And so it's into that space that there's more egg freezing and embryo banking. So the idea behind egg freezing is perhaps somewhere over the age of 27, a person, even with polycystic ovary, might choose to freeze a set of eggs. Probably not for having their first baby. I mean, hopefully this person will be able to conceive naturally at age 32 or 34 or 36, and then maybe want to have a second baby or a third. And that's why people are freezing their eggs, or that's why people are freezing embryos. It's for their future selves, their 37-year-old self, or their 39-year-old self, or their 41-year-old self, who really could use donor eggs at that point, and effectively you're becoming your own egg donor.
Yeah, okay, and that's actually great. So this is another reason why then people are doing multiple rounds of IVFs, right? Because it's like, oh, well, maybe this is enough for one baby, but what if I want to complete my family by having 2 or 3 kids?
You're right, totally, Mary. But women with polycystic ovary, if they're lucky, it all happens on that one cycle, right? They're in this privileged position of having so many eggs that if the cycle's well run and they go to a good clinic, there's a very reasonable hope for them that they will literally only have to do it the one time, that they won't have to go through multiple cycles.
All right. And but what if? Because we're always going to deal with the what ifs. So there's not that many. Like, you know, what is, you know?
Yeah, totally.
Like if I end up with 2 embryos. Am I going to go, is there a baby in there? Is that 1? Is that 2? Is it 0?
Yeah, and that's when it's a reasonable conversation. And like that's so now we're getting into super individualized medicine, but you would very much want to know, as someone who came into IVF with a diagnosis of PCOS, how is it that there's only 2? Like, what happened exactly? Was there a surprise? You know, it really is tricky to get the medication dosing right the first time someone goes through. So it's possible that that's all the issue was, and that a rebalance of the medications will yield a better outcome. Maybe we did uncover a challenge with the lab for their eggs, or with their overall health, or sperm or egg health. But and for those people, it's a pretty personal conversation as to whether they should be doing more cycles or not.
So I think what we're addressing is personalized care, right? Where nobody is part of a cookie cutter.
Right. So I'd like to bring this back to where you come in, Mary. How do you find your role as for your patients who are going through IVF? What do you see as the essential value that you're providing?
Okay, that's a really great question, and I appreciate that. And you know, when people come in, like you say, first of all, nobody wants to do IVF.
Nobody wants to do
really.
IVF. Yeah,
like, let's be honest.
No.
And if you're going
that's why we talked about the 3 to 6 cycles first. Like most people would try the letrozole for a couple months.
Of course.
But sometimes IVF becomes the right thing.
Right, and so if you're going to do IVF, or having the privilege of living in Ontario, and you're waiting around for that funded IVF cycle, well, you want to know that you can take some kind of control, some semblance of control in your own health and your own egg quality. So most people that come in, they want to actually optimize their egg quality, and also simultaneously decreasing their stress levels and stress response. So every time that women come in, I say, you know what? I get, of course, you want that baby in your belly, but first and foremost, let's get you balanced. Let's get you feeling better about yourself, both physically, mentally, emotionally, and we'll go from there. Because sometimes you never know. All of a sudden, your adrenals your adrenal cortisol levels will go down, and perhaps the hormonal cascade of hormones, like between the hypothalamus, pituitary, and ovarian function, might actually work better. That does happen. We'll see people have more normalized cycles, especially in the case of PCO.
Yep, totally.
You know, going from anovulatory or long irregular cycles to actually now regular.
Yep.
And sometimes working together, they're actually getting pregnant before they do their IVF. And of course, that's great. And it certainly doesn't happen all the time. And if that's the case, then yes, okay, why don't we optimize your IVF cycle? So we're working with them prior to help optimize their eggs and their quality. And then during the IVF cycle, it's like their last kick in the can, right? So that's why I say, oh gosh, find out where your follicles are, how many there are, and what are the sizes as you're stimulating, and we may do certain very, very specified stimulations.
Mary, can you think of any stories recently, like a specific patient that, and what her IVF journey was, or how it might have differed from what she thought it was going to be?
Are you thinking someone with PCO, or?
Yeah, someone with PCO. Yeah, like someone who might represent the typical concerns that someone would have before they go into IVF, and then what their actual lived experience was.
There's so many people.
I know it's a tricky question, isn't it? What I find is that there's just such a discrepancy between the worries that people have about what the experience is going to be and then what their lived experience is. I'm not saying the lived experience is always good. I'm just saying it rarely connects with what the worries are. For example, a lot of people are worried about the egg retrieval process, which really isn't a thing by itself. Because they're medicated.
Yeah.
People are, if it's done properly, they won't even remember that day. IVF is consequential, but the retrieval day, not so much.
Yes, okay. There we go. You know what? I'm actually going to bring up this one patient who's currently, I just found out she's pregnant. She's had 3 beta HCGs done. She's a single woman, and she's around 40, and she has PCOS.
Wow. Okay.
And she's has a high BMI, and so worried about her weight not being perfect, but she was getting IVF funding. I said, don't worry about it. I said, you do the best that you can, and simultaneously, the big thing is let's just decrease your stress levels on the spot, and know that you don't need to be stress-free and perfect. The point is, you don't need to be perfect to get a baby.
I love that. Yeah.
Right?
Yeah.
So we optimize, that's it. Like, we deal with what we've got, and we're going to go with it.
Was she able to hear you in that?
Yes. I was coaching her on that. It was difficult for sure.
Yeah.
So I literally made her do certain strategies, like in her day, like, let's set an alarm and, say something positive to yourself every hour, or, things like that, right?
Yeah.
Anything that can help you through your journey, because I'll tell you, this little hamster wheel is churning 24/7. It doesn't stop. And how do we if we just mitigate that churning, even 5 minutes at a time, that might be enough to downregulate that whole sympathetic nervous system.
Yeah.
Right? And things will work just a little better. And so when she did her IVF, and she's all panicked because she was like, okay, I think I need to do multiple rounds because, I'm thinking, I forget, I think she's over 40. Maybe she's 41, something like that. And so in her mind, she might have to do multiple rounds. But I said, why don't we wait and just, let's see what we've got. And in her case, and I don't remember why, but she wanted to do fresh embryo transfer. So back in the day, that's all everybody did. So now with more data, people are doing the freeze-all concept, but it doesn't necessarily mean you cannot get pregnant with fresh embryo. And so she opted for that, and she has a couple of frozen, and she's currently pregnant.
Nice.
So, you have the worst fears, and because she's single, and her father is not supportive of this. So there's just so many layers.
Lots of layers of things, yeah.
Yeah, right.
Well, I like the idea of working, of optimism, yes, but also of working towards optimizing one's self, but not having to hit certain specific goals. You mentioned weight. So weight is an issue around PCO, for sure, and it's an issue around IVF. It's true, to have if a person's overweight, it is harder to get the stimulation right. There is a lot of incentive to be losing weight. But then an interesting thing about PCO, there's some really good studies showing that as long as the lifestyle is taken on, including eating properly, within 2 to 3 weeks, even though weight itself might not have changed that much, the ovarian response and the egg quality that results from those cycles is substantially better. So people can try to be aiming for some specific weight goal, and if they need to do for their overall health, okay. But more often, if they can just take on that lifestyle, regardless of the weight that results, just taking on the lifestyle alone is going to make a big difference.
Absolutely. So I'm going to actually counter what you just said, because really you're saying the same thing. I would just say drop the focus on any amount of weight, because that should be a natural response to lifestyle change.
I want to agree with you, except for medical safety reasons, when we're sedating somebody, sometimes there actually is a cutoff. Like they're actually
right. Got it.
Yeah.
Unfortunately, guys.
No, that's a real thing.
Right.
But below that, yes, it's not about a specific number so much as an optimized, working towards an optimized lifestyle.
Right. So, and because when we don't focus on the numbers, some women will experience weight loss anyway.
Right.
And just the momentum of weight loss or the momentum of having a better lifestyle will have your body just function that much better. Right. So it doesn't need to be perfect. You don't need to be Twiggy. I'm dating myself. Nobody knows who Twiggy is anymore.
I have a grade 9 daughter who was looking to wear a dress to a semi-formal. Terrifying as she expresses all the... And so my wife brought out a Twiggy dress, and my daughter was not going to have anything of that. That was not going to... that was not going to be it.
Okay.
During our conversation, the door's been opened a couple times. I'm getting called out.
Yes, we gotta go. Oh,
yeah.
Absolutely.
Okay,
We've been talking way too long, but very essential, very good conversation. So thank you so much for being here.
Thank you so much.
Thank you.
And thank you for everyone who chose to listen to this. We're doing this because we really believe, both Mary and I really believe in the importance of education, so that people are in a position to make the decisions that are best for themselves.
Yes. Yeah, rather than just going to Dr. Google, where you can go swirling into information that you don't even know what's up.
Yeah.
Right? So we're giving you professional information. So I hope this empowers you and you have informed choice.
Yeah.
Okay, guys? So like it and scroll down below for more posts. And in fact, you can go onto my YouTube, which is Mary Wong Acupuncturist, and there's like over 140 posts. Okay, guys? We'll see you next time, and have a great week.
Thank you, Mary.
Thank you so much.
Yeah, thank you. You too. Okay.